welcome everyone to our Croí Connects series, where we aim to get answers to all your burning cardiovascular, health and lifestyle related questions. This week we're here with Darren Mylotte, consultant cardiologist in Galway University Hospital, and we're going to discuss heart valve disease. Thank you for joining us, Darren. We know from our talks and our screenings out in the community that there's a huge lack of awareness and understanding of valve disease. So people don't see it as something different from coronary disease. So to kick it off and to begin with, can you tell us how you explain valve disease to your patients so that they understand the difference, perhaps?
Sure, thanks for having me on, Patricia. Obviously coronary artery disease relates to a disease of the coronary arteries, and problems with the coronary arteries can, for example, cause heart attacks. On the other hand, heart valve disease is a disease of the heart valves, of which there are four, two on the left-hand side of the heart and two on the right-hand side. And if those valves become faulty, well, then they can lead to a particular group of symptoms that can cause problems for patients, and of course can shorten their life. So heart valve disease, in essence, in its very essence, is a disease process involving the heart valves, of which there are four. Those heart valves can, one of two things can happen to them really. They can become leaky or they can become blocked. And we refer to leaky valves as having regurgitation, and we call blocked valves stenotic or have a stenosis, in the same way we would with a coronary artery stenosis. And in effect, a leaky or a blocked valve can, over time, if it progresses and becomes severe, can cause symptoms for the patient and affect their quality of life, and can also shorten their life, and thus require treatments that range from tablets to valve replacement surgery.
And how common is this valve disease, Darren? Are we seeing a lot of it, or are we diagnosing much or little?
Yeah, so there are probably two peaks of heart disease, Patricia. One happens to be in young kids and in babies who are born with congenital heart disease. And we don't hear a huge amount about that because they tend to be whisked off and treated very early in life and do very well. But certainly we're seeing a resurgence in heart valve disease in elderly patients. And that's because much heart valve disease is part of the aging process, in the same way as a hip joint or a knee joint might give you discomfort or cause you trouble later in life. A heart valve can undergo the same wear and tear or aging process and causes difficulty later in life. And while patients, of course, used to die from their heart attack or die from their cancer, the improvements that we've seen in care for many conditions lead to patients living longer, and therefore we see much more heart valve disease. So it's estimated that heart valve disease occurs in between about 5 and 7% of patients over the age of 75. And so largely it's a disease of the elderly.
Okay, and that was the next question, actually. I was going to ask you, is it age-related? So if it is age-related, should we be automatically screening everyone over the age of 65? Like, would an annual stethoscope check, listening to the heart, would that be sufficient to screen for it? Yeah,
so largely heart valve disease is age-related. You can have some conditions that predispose to it earlier in life. So for example, there's a condition associated with the aortic valve called a bicuspid aortic valve. And this is a common genetic problem occurring in 1% of our population, where their aortic valve has 2 leaflets rather than 3, and that can predispose to early degeneration. But the vast majority of people who run into trouble with their aortic valve do so later in life. In terms of screening, well, it's difficult because most of us throughout our lives will develop some form of heart valve disease. And of course, that can be classified as mild, moderate, or severe. And it's really only when we get to the severe level that it affects our quality of life, that it gives us symptoms, and it affects our quantity of life. And so the idea has to be therefore to not really screen for mild valve disease, but really try and find patients who are experiencing or at risk of moderate and ultimately severe heart valve disease. But certainly the most effective way and the cheapest way is the stethoscope exam. Echocardiography, or getting an ultrasound in your heart, is of course the most effective way of determining if you have heart valve disease and if you do, what severity it is. But echocardiography is not widely available for GPs in the community, and therefore screening with a stethoscope and figuring out who's got a murmur and referring those patients for further assessment is the right way to go.
Right. We hear that out in the community. Many older people tell us that they get a new lease of life almost if they have a valve replaced or repaired. So how important is it that we detect that valve disease kind of at an early stage or get it treated quickly?
Yeah, I wouldn't say getting it at an early stage is particularly beneficial, because we only treat it when it gets to the severe realm, when it causes problems. So if, for example, you, Patricia, had mild or moderate, be it aortic or mitral valve disease, we would keep an eye on that, but we wouldn't treat it. We would, of course, ask you to watch your blood pressure to make sure that's well controlled, to remain physically active, to make sure that your cholesterol is well controlled, because if you're going to go for valve surgery, well, the surgery will be easier if you don't have problems with diabetes, obesity, if you're physically fit. But not getting it early, but getting it at the right time is important. And so I think an awareness of symptoms is very important for people in the community. If you're breathless, if you're having dizzy spells or blackouts, or if you're getting a tightness or a squeezing in your chest when you exert yourself, those three really are the cardinal symptoms of heart valve disease, and certainly something that the community should look out for. And if they're experiencing those symptoms, of course, a visit to the GP and a stethoscope exam is important. There are, of course, many other conditions, such as lung disease, COPD, coronary artery disease, and so forth, that can cause those exact same symptoms. But a GP can, or a doctor can usually figure that out, usually with some simple tests, such as a stethoscope exam, a chest x-ray, some blood tests, and so forth.
And you mentioned just there, because I was going to ask you about symptoms, but you've covered that. But you mentioned about a murmur. Are all murmurs suggestive of valve disease? So
a murmur is essentially turbulent blood flow. So if you're standing at the Corrib Lake, you can't hear the water moving. It's moving, but you can't hear it because the flow is laminar. The flow is very smooth. If, on the other hand, you're standing at the entrance to the Corrib into the sea, you can hear that very fast flowing water because it's not laminar flow, it's turbulent flow. And that's all a murmur is. A murmur is a sound that is caused by blood rushing through a valve. And blood would only rush through a valve if that valve was either blocked or leaky. And so a murmur is a sign that there may be a problem with one of the heart valves, or you can have a murmur from other conditions in the heart, such as having a hole in the heart. Some murmurs are absolutely benign. For example, murmurs of pregnancy are very common. It's related to increased blood flow during the period of pregnancy, particularly in the second and third trimester, but they don't require treatment and very often don't require investigation. If, on the other hand, you have maybe an elderly patient who has a new murmur, who's getting breathless, that's certainly something that certainly does need further evaluation. Again, initial detection of that murmur with the stethoscope is crucial to the subsequent referral for the further investigation. Okay,
that's really helpful, and that makes it quite clear actually for everybody. So they were kind of just some general questions around valve disease, and then we put it out to the community just to see if anybody had any particular questions. And Pat, who's 71 from Castlebar, contacted us, and he wants to know if he should be doing anything in particular. His GP has heard a murmur, and he is being referred for investigations. Anything you'd advise him to be doing in the meantime?
Well, I think first of all, for Pat to get to know his symptoms would be very important. So has he had a change in his exercise capacity? Is he able to walk on the flat? If so, how far? Can he get up a flight of stairs, or can he get up the hill? Has he got some swelling in his ankles? Is he getting tightness in his chest? Has he had any dizzy spells? These are all the questions that he's going to get asked when he presents for that further assessment. And so very often going for a walk and seeing what you can do and see how it relates to what you were able to do maybe a year ago is a good way to understand where you are. It's also important that patients who might have significant heart valve disease don't push themselves too hard until they know exactly what they have. So if Pat is having symptoms, I would suggest keep exercising and keep yourself fit and strong. That's very important, but not to the point whereby you're experiencing those symptoms if indeed you are having symptoms. And otherwise, standard things apply. Eat well, mind your blood pressure, check your cholesterol, because we really believe that these are associated with valvular heart disease progression. So the usual advice from cardiovascular doctors.
Great. That's really helpful. And those lifestyle issues are always so important for all types of cardiovascular disease, and I suppose for anybody growing older, because some people kind of they recognize those symptoms, but they consider it's just an aging process.
Yeah, and one of the things we very often see, Patricia, even when people present with very severe and very advanced heart disease, is that they can, particularly elderly patients, be a little bit unaware of their symptoms because they feel that it's part of the aging process. For example, they stop walking up the hill when they get breathless, and they don't go out and they maybe take to the bed or whatever, rather than thinking this is unusual for me. I used to be able to do this a couple of weeks or months ago, and maybe I should get this investigated. So it's not uncommon for us to meet patients and we ask them, do they have symptoms? And they tell us no, whereas maybe their son or daughter is sitting in the chair beside smiling saying he's unable to walk to the bathroom now because he gets breathless. And so we would simply get the patient out onto the floor of the outpatient department and get them to walk, and you can see very, very quickly whether someone has difficulty breathing when they're walking or not. So as I mentioned for Pat, very important to understand what your symptoms are now. What can you do, and relate that to what you were able to do 6 or 9 months ago, and see if there's a difference.
Great. That's really good advice. I hope Pat takes it on board now. Jack then, who's 68, and he's been told that he has mild aortic stenosis, and you mentioned that earlier. He has an echo about every year, but he's wondering, is it likely to get worse?
So that's a good question from Jack. So mild aortic stenosis tends to get worse, but it does so very, very slowly. So what we would normally do with someone with mild aortic stenosis is to do an echo once to make that diagnosis, probably having the GP having found a murmur. And then we would do an echo in 12 months' time. And if the progression of that heart valve disease was as slow as one would expect, then we would say, look, Jack, go away and we'll see you in 3 to 5 years and repeat the echo at that stage. Knowing that the vast majority of people who have mild aortic stenosis will still have mild aortic stenosis in 3 to 5 years. And if they are going to progress rapidly, we will pick them up in the moderate phase. So it's very unusual for someone to go from mild aortic stenosis, for example, to severe aortic stenosis over a period of 3 to 5 years. So what I would suggest to Jack is more important is watch his symptoms. So if he's largely asymptomatic, stay fit, mind your blood pressure and your cholesterol, and get an echo every 3 to 5 years. But if it does progress, it tends to be quite slow.
Great. So be aware, mind yourself, but not worry too much about it.
Not about mild heart valve disease, no. And I mean, there is controversy about whether we should even follow mild heart valve disease, because all of us to some extent have some degree of leak or some degree of narrowing, in the same way as some of us have 1 or 2 of our joints that aren't as agile as the others, yet we don't follow those with routine x-rays or so forth. So if you know that you have some mild form of heart valve disease, there's absolutely nothing to worry about. The chances are that you will never need anything done about that throughout the course of your life. But a follow-up ultrasound in 3 to 5 years, it kind of, I suppose, helps reassure you in that respect that we're not going to miss anything. So Jack has been very closely looked after, and I don't think he has so much to worry about at the moment.
Great, that's great. So then we have Annie, who's just 55, and she contacted us from Donegal. She's been told she has a bicuspid valve, and you mentioned that, but she's going to need surgery. And she's been having some shortness of breath for years, but lately has noticed that she's been struggling with it. And she's wondering, is surgery absolutely necessary? And if so, how should she prepare for that?
So, so obviously I don't know the specifics of Annie's case. So what I'm going to mention will be general rather than specific to Annie. The first thing to talk about is, of course, bicuspid aortic valve. And this is the most common genetic heart disease that we see. This is very common. It happens in about 1% of the population, and usually has a predilection for males, actually. So Annie's a little unusual. It's 3 times more common in men than in women. And what it means is that the aortic valve, which sits at the top of the heart, normally has 3 leaflets. It's a tricuspid valve. Annie, on the other hand, has 2 leaflets. It's a bicuspid valve. And what it means when you have a valve that has 2 leaflets is that it tends to wear out a little bit more quickly. Now, the more severe bicuspid valves will wear out in the late teens or the early 20s, but there are various degrees of what we call bicuspidity, and so that it can really tend to wear out at any stage throughout your life. The important thing with a bicuspid valve are 2 or 3 things. The first is that it tends to run in families because it is an inherited disease. And so the first thing to mention to Annie is that if she has it, all of her first-degree relatives need to have an ultrasound to see, do they have it? Because if Annie has it, it means that 1 in 5 of her relatives could have the potential to have it. So family screening is very important. The second issue that we see in patients with bicuspid aortic valves are that it's not just a disease of the aortic valve. The aorta, which is that large blood vessel that comes up off the top of the heart and brings blood all the way around the body, can also be involved in this genetic disorder and can dilate, which means it gets larger than it should do. And so anybody with a bicuspid aortic valve, we have to watch not only the valve, but also the aorta to see if that gets too big. And about 40% of people who have a bicuspid aortic valve will have a problem with their aorta as well. So there are 2 really disease processes that we need to watch in people with bicuspid valve. Outside of that, in relation to Annie's symptoms, I would say that anybody who has heart valve disease who is breathless absolutely needs to be evaluated by a cardiologist. And if that breathlessness has recently increased, again, that's a clear sign that she needs to get back in there for an evaluation. She doesn't need to come into the emergency department overnight or anything along those lines unless she's really struggling. But certainly, you know, a review with a cardiologist would be appropriate. So we would see a lot of patients who have moderate and sometimes severe bicuspid aortic valve disease, and we would see them every 6 to 9 months, re-echo them. And we would also say, look, if you're having symptoms, give us a call and come back and see us sooner. It's not always easy to do, but if any of us get a letter from the GP, for example, or from the patient themselves that says, look, I'm in your clinic and I've been ticking along quite nicely, but things have changed for me, that's you know, certainly a reason for us to get that patient in and evaluate them more quickly. Maybe the final part of Annie's question relates to, will she need surgery? And we know that 60% of people who have a bicuspid aortic valve throughout the course of their life will need surgery. So about 2 in 3 people will need that aortic valve or aortic root replaced throughout the course of their lives. So it depends on where you are in terms of your heart valve disease, whether it's mild or moderate or severe. But keeping in touch with the local cardiologist, I think is very important, particularly when you have something like a bicuspid aortic valve.
Great. Good advice for her. That's excellent. Thank you. The next question is that Noel asks, will he have to take warfarin indefinitely? I'm presuming that he's had a valve replacement, and he's wondering, or he's going to have it, or he's wondering about the new oral anticoagulants and what the difference is. Now, we probably don't have the scope to go into too much detail on this, but what's your feelings on this?
So I suppose if you go for heart valve surgery, traditional heart valve surgery, the surgeon can implant 2 different types of valve. They can implant a metallic valve, which requires warfarin treatment for the rest of your life. not one of the new anticoagulants, because there's been one study done that suggested that the new anticoagulants were not as effective as warfarin. The reason you have to take that blood thinner is that you can get clotting on the heart valve. And if the heart valve clots, you're in big trouble. And so if you go for a metallic valve, you will require warfarin for the rest of your life. If, on the other hand, you go for a bioprosthetic, that is a pig or a cow valve, then you usually require warfarin for a period of about 3 to 6 months after the procedure, and then you can stop it. And more recently, they have substituted the warfarin for a novel anticoagulant for that period, and that seems to be very safe. The disadvantage to the bioprosthetic valve is that it's probably going to wear out in between about 12 to 15 years, and you will need another heart valve replacement. And so if you, for example, have valve problems at 40 years of age, you might want to opt for the warfarin valve or the metallic valve and accept warfarin for the rest of your life, rather than, for example, having 3 different bioprosthetic valves, assuming that you're going to live until your 80s. So the advantage of the metallic valve is it doesn't wear out. The disadvantage is that you need warfarin. The advantage of the bioprosthetic or the pig or the cow valves are that you don't need warfarin, but they can wear out and you might need another operation. And therefore, for much younger patients, and the average age for the aortic valve is about 60, the average age for the mitral valve is about 65. If you're under 60 to 65, we would probably encourage you to consider the metallic valve. If you're over the age of 60, 65, we would encourage you to have the bioprosthetic or the cow or pig valve. And that relates to the amount of your life that you're going to have left and the requirement for a reoperation. There has been a vote more recently to be able to avoid a second operation by doing a TAVI, for example, which is a valve that we can put in through the leg inside a failed pig or cow valve, and that makes things easier. But still, I think a good discussion with your cardiac surgeon about what type of valve you would like, about whether you would prefer to have warfarin for the rest of your life or the risk of another operation in due course. And very often the surgeon takes into account the patient's preference. So a good, discussion and risk-benefit discussion between the patient and the surgeon, I think, is what makes that decision ultimately.
That's great. Thank you. That's lots of information there for Noel now to consider for sure. My next question is from John in Connemara, and he's been told he needs a valve replaced, but it's going to be done through his arm, and he's quite shocked that this is happening. I'm taking it that they're talking about a TAVI, but that's what he wants to know. He wants to know what are they talking about.
So it sounds like a TAVI. Now a TAVI stands for transcatheter aortic valve implantation, and that means that rather than open heart surgery, where you go for a general anesthetic, you have your chest opened by a cardiac surgeon and get put on a bypass machine, and where they will remove the old valve and replace it with a new one, and then start the heart again. That's the traditional way of doing surgery. It's been around for 50 years. It's very successful, but it can be tough to get through, and particularly for elderly and frail patients. And therefore, about nearly 2 decades ago at this stage, we developed transcatheter aortic valve implantation, which is really placing the heart valve not through the center of the chest wall, but through the leg, through an artery in the leg, and through a catheter. And this pretty much has revolutionized the treatment of heart valve disease, particularly for patients who have aortic valve problems. And what that means is that for the more elderly or the more frail patients, rather than sending them for an open heart surgery that either they may not survive or they will have a real difficulty getting back to their previous level of functioning, that we would opt to try and replace that heart valve through the leg. We initially started this process with very elderly and very frail patients, so patients over the age of 85, but we've subsequently done studies in patients down as far as 75 years of age, and it's been shown that this technology in those patients tends to have less death, less stroke, less kidney injury, less bleeding, less hospital stay, and a quicker recovery than traditional aortic valve surgery. And so in our institution, most patients who are over the age of 75 who need to have an aortic valve replaced would have a TAVI. If you're under the age of 75, you would tend to have traditional surgery. But of course, that has to be on a patient-by-patient basis, because some patients, for example, would have severe coronary artery disease as well. And we would elect to send them, even if they're elderly, maybe for surgery, because the surgeon would be able to do a bypass at the same time as doing a valve replacement operation. So all cases of severe heart valve disease in this institution are discussed together by the surgeons and the cardiologists. We come up with the right decision for the patient, involving the patient in that decision. But as a general rule, the more elderly and frail patients tend to go for a TAVI, which is a valve through the leg, and the more robust patients tend to go for the traditional open heart surgery.
And you mentioned there that it's discussed with the team, and also it involves the patient. How involved are the patients in that decision making around the valve?
Yeah, I'd say the patients are very involved in that decision. I mean, it depends on the patient, I suppose. So if you're 85 years of age, really there's the two options for you are to have a TAVI or to have medical therapy. And we know that medical therapy is not really effective. But nevertheless, we sometimes see patients who are very frail, maybe nursing home residents, maybe cognitively not very good. And we would suggest that they have medicines rather than any intervention such as a TAVI or surgery. And we would try and involve the patients and their families in that decision. In younger patients, again, it's a fairly straightforward decision because their risk of a bad outcome with surgery is very, very small. And we do see sometimes some younger patients who absolutely want to have a TAVI. And if that's what they want, well, that's okay. There's no problem. We'll discuss it with the patient, as long as they understand the risks and the benefits of each procedure, as long as they sit with a cardiologist who does the procedure and they sit with the surgeon who does the procedure, then absolutely we take their views into account. But most of the time, Patricia, it's a discussion between the patient and their doctors, and the decision is one that's fairly easy to come to. And we would not enforce a particular treatment on a patient. Those days are long gone.
Sure. And Darren, how successful is TAVI? How successful are the less invasive techniques?
I think it of course depends on the patient that you're looking at. If you're a very low risk patient, well, your risk of problems is very low. And if you're a very high risk patient, well, then your risk of complications is higher. So rather than say what is the risk of or what is the chances of success, you have to compare it to the alternative, which is surgery. And what we know is that the short-term outcome of TAVI out to 1 year, there's less risk of death, less risk of stroke, less risk of kidney injury, less risk of bleeding, less risk of vascular complications, quicker recovery, shorter hospitalization with TAVI compared to surgery. On the other hand, there's a higher risk of having some leak around the valve or of requiring a permanent pacemaker compared to surgery. So there are advantages and disadvantages to both of these techniques. By and large, 98% of patients that we send for heart valve surgery get out of the hospital and do very well. And 98% of patients who come in for a TAVI get out of the hospital and do very well. So both procedures tend to be very successful.
Great, thank you. Just considering the times we're in now with COVID-19, what sort of impact has that had on your service, on valve disease patients in the west of Ireland here, around, you know, appointments, follow-up, diagnosis and treatments?
Gee, where to start?
Yeah,
I mean, it's obviously affected. There's not a facet of our lives that this virus hasn't affected, and so our service is no different. We would have had an outpatients every week where we would see 20 patients with heart valve disease, a specific dedicated heart valve disease clinic that hasn't run physically for now 4 months. And so we call each of those patients, but many of them have not got their follow-up ultrasounds and so forth that they should have got either post-TAVI or if they're awaiting a procedure. So it's affected our outpatients. In terms of our inpatient procedures, well, they were cancelled pretty much for 3 months, and we were only able to treat patients who really needed it to get out of the hospital. We did do some TAVIs during the lockdown, but they were relatively few and far between. But for the last 3 to 4 weeks, we're back up and running our inpatient service and our elective TAVI service as normal, because many of these patients can't wait. And at one stage, I think 60 or 70% of our inpatients, our cardiology inpatients in the hospital, were awaiting TAVI. So many of these patients do okay once they've been diagnosed if you get to treat them relatively quickly. But if there's a delay in their treatment, then they really start to struggle and they end up in hospital with heart failure and breathlessness. So hopefully, Patricia, we're back up and running. We have a little bit of a backlog. That's going to take some time to clear, but we're normal services resumed as of from about 3-4 weeks ago.
That's really good to hear, because, you know, obviously it has affected the services across the board. So it's really good to know that you're up and running again and getting back to normal services. Thank you for being with us today. Have you any last words or key messages that you'd like to communicate to our listeners?
Well, I suppose that I think the most important thing is that if you're worried about heart valve disease and you have those symptoms, which again are breathlessness or chest tightness or unexplained dizzy spells or blackouts, that heart valve disease, you know, is a problem that can be diagnosed with a clinical exam using a stethoscope and then usually a follow-on ultrasound study. That heart valve disease is absolutely treatable. The vast majority of patients get a successful treatment and get home and get better and get on with their lives. And so if you're experiencing those symptoms, please present to your GP. Please present to your hospital if that's the case. Many of the patients who have heart valve disease, Patricia, are going to be afraid to come into the hospital. They've heard a lot about COVID. And COVID is very important, but we do have separate streams for potential COVID patients, and they're kept way away from anybody who's clearly not a COVID patient. And so please don't be afraid to come to the hospital if you have symptoms. Your care can't wait. So come and see us. We're open for business. That's
great. Thank you so much, Darren. For joining us here on the Croí Connects. We really, really appreciate it. Lots of really positive messages out there for our public. So thank you. Croí Connects returns in 2 weeks' time. Just keep an eye on our website and our Facebook page to see who's up next. Lots of great resources. Follow us on Facebook and Twitter and Instagram. You'll find us at Croí Heart Stroke. Thank you for watching, and bye-bye now for today.